Thank you all for being here. My name is John Morris, and I have the honor of being the director of the Knight Alzheimer's Disease Research Center and the Memory and Aging Project at Washington University. And all of you are here because you are connected to those programs. And I want to tell you that we have two purposes of having this annual participants meeting. The first is we want to share with you some of the research progress that has been made, particularly in some of the studies in which you may have participated, because we see you as our partners in research. We're all trying as hard as we can to defeat the dementing disorders, particularly Alzheimer's disease. So we want to update you on what has happened in research and what we are thinking about for the future in research. And second, we want to thank you for your participation. You are all volunteers who come at least once, often twice, often several times a year to be in our studies, and we know we have the best group of participants in any research program anywhere, so we thank you. Thank you very much. Now, I've been told a number of things and I'm supposed to communicate to you as housekeeping items, and this is a sad commentary. I didn't write them all down, so I don't know if I'm going to remember all of them. But the first thing is we should take our cell phones or whatever we have and put them on vibrate or off or something like that. So let's do that. Second, somewhere, somehow, someone may be missing this beautiful scarf, and I'll put it up here, and if it's yours, just come up to the podium after the program and claim it. Third, I'm told that the two breakfast offerings in the corner of the room, not the one in the lobby, but the two corner room breakfast buffets will stay open, and you're welcome at any time to get up and refresh yourself. I've been telling some of you, and none of you have believed me, which is good, that I was up all night cooking, but for this, I think we should let all of you know that our staff at the Memory and Aging Project, everyone works very hard in trying to put together this program and the food and the coffee and so forth, because they are genuinely interested in thanking you for your participation. So I'm not going to introduce individually all of the investigators and staff of the Memory and Aging Project, but I will ask them now to either stand up or move forward so people can see you. So everyone who's in the Memory and Aging Project, staff or faculty, stand up, and let's thank them. And finally, the restrooms are just outside the lobby. Dr. Buckles, we're just right outside the lobby, and we'll guide you if you need some guidance. All right, so you're here to learn about what's been happening. So let me launch into this. I want to bring you up to date in this time, June 8th, 2013, about what's going on in our Memory and Aging Project at the Knight Alzheimer's Disease Research Center. So in many ways, it's the best of times. I came to Washington University in 1982 joined what then was the Memory and Aging Project in 1983, and I can attest that this is by far the most exciting time in Alzheimer research here at Washington University and across the world ever. We've all been told that the only way to know for certain that someone has Alzheimer's disease is to examine the brain after death at the autopsy, and that's still critically important, and you're going to hear about that. But we are now developing tests. We call them biological markers or biomarkers that can identify the disease in living people. In living people. We never before have had this. And we have really promising therapeutic agents that aren't aimed at just trying to help the symptoms of Alzheimer's disease, but to try to stop the disease process, halt it, and we'll talk about this, if we're able to initiate those agents very early, it's possible, at least theoretically, that these drugs have a chance to prevent the onset of dementia. We'll come back and talk about that. So the most exciting time ever, the most promising time ever. But it's also the worst of times. All these disease-modifying drugs that I've been talking about, they have such great promise to halt the disease process. In the past 13 years, there have been about 15 trials of those drugs in people with Alzheimer's disease dementia, and none of the drugs have worked. None of them. They've all failed. We'll come back and talk about that as well. And perhaps the most discouraging of all, when we're poised to launch prevention studies trying to stop the onset of dementia, the funding isn't there. And this is related, of course, to all the difficulties that we're having in administration and the Congress about trying to work out a reasonable budget in these difficult times. And unfortunately, it affects, of course, everything, and it does affect the major funder for biomedical research in the United States. That's the National Institute of Health. So funding has become more and more difficult just at the time when we need more and more funding to capitalize upon our advances. Let me just put this in proportion for Alzheimer's disease. The red bar is how much money each year the United States pays to take care of people with Alzheimer's disease dementia. $200 billion every year in the United States alone. Now you would think, given the enormity of this spending, the public health implications, that research would match that. We'd have this amount of research to try to combat this terrible illness. In actuality, this is how much the NIH spends. Really less than $500 million a year in something that costs our country over $200 billion a year. By the way, we all know that this is only going to get worse as our population continues to age. So there is terrible disproportion in spending for research to try to beat this disease compared to what it cost us. For every $400 spent taking care of somebody with Alzheimer's disease dementia, we spend $1 on research. For heart disease, it's a 25 to 1. It's better, it's not great. Heart disease is another major killer. For cancer, the ratio is even better. So Alzheimer's disease, among the major killers, has the least amount of research funding. So this is just one way, another way to look at it. The purple bar, the low bar, is how much Alzheimer's disease research dollars there are every year in comparison with cancer, heart, and HIV/AIDS. These are all terrible diseases. They all deserve funding so we can cure them. But Alzheimer's disease, disproportionately less. And guess what? We get what we pay for. For all those other diseases, the bars there in color and magenta and yellow and green and red show that the proportion of people dying from cancer, from heart disease, from stroke is decreasing. The only major killer for which deaths are increasing is the purple bar, Alzheimer's disease. So that's the worst of it, the worst of times in terms of funding. Now I want to be clear about the use of terms. Many of you, when you come for your annual studies and assessments, come to the Memory and Aging Project. We call it by short MAP. MAP actually began in 1979. It's long running. My predecessor, my mentor, Leonard Berg, was the original director of the Memory and Aging Project. And in 1979, I can tell you very few people knew about Alzheimer's disease. And if you use that term, Alzheimer's disease, it had a terrible stigma. People were crazy, should be locked up. So they deliberately chose not to term this Alzheimer's disease project, but Memory and Aging. Today we continue that name for the office where you come for your assessments of memory and thinking on the euphemistically named first floor of our building. And we continue to stay there. And some of you may have been there in the past couple of months, and we've had a little bit of a facelifting and some renovation, and we're very pleased with our facility now. As I mentioned, the Memory and Aging Project began in 1979. All of our assessments are supported by funding. We call it a grant that we get from the NIH. These grants are competitive. We apply for the funding, and we're rated by a review panel, and if we're scored well and the NIH has money, we get the funding. But it's becoming tougher because there are many other worthy research projects that are competing for the same limited research dollars. We have 4 major grants. We're very fortunate at the present. I'm going to talk about those in a moment. And it doesn't matter which particular grant that we have that supports your participation, pays for the assessments, for the scanning and so forth. We all see all participants from no matter what grant they're supported at the Memory and Aging Project. That's where you come for an assessment. We deal with which grant supports which particular study. Now our facility, our Memory and Aging Project facility at 4488 Forest Park does not have imaging scanners and things of that sort, so you do go to other parts of the Washington University campus to get some studies, but the central study is the Memory and Aging Project. Now, you have at the beginning of your handout at your table a larger version of this slide. I show this because I think this is a unique time. We have really been, as I say, very fortunate and very successful to be awarded these 4 large grants. And some of you were noticing that in a recent copy of the St. Louis Business Journal that there was a story about this, and we have, if you total all the funds from all these grants from all the years that they're awarded, it's something a little over $50 million. So that's really a it's amazingly high percent of allows us to do our work. The 4 grants have different names. The one you may have heard about is the Knight Alzheimer's Disease Research Center, or ADRC. But we also have grants called Healthy Aging, Senile Dementia, the Adult Children Study, and the Dominantly Inherited Alzheimer Network. No matter which grant under which you're enrolled, you are evaluated and assessed at the Memory and Aging Project. We use the term Alzheimer's Disease Research Center, Knight ADRC, as our calling card to the world. People often refer to us as the ADRC, and it's a very important grant, but it's one of 4. So I just wanted to explain that. I say that we're really fortunate. I don't think we're going to be able to sustain this because of the dire funding constraints at the National Institutes on Aging, but right now we're very fortunate, very successful. All right, let's talk a little bit about you. So the total numbers of people in the healthy aging and senile dementia and the ADRC studies, those are people 65 and older, including people who have mild Alzheimer's disease dementia, but also including people who are perfectly healthy in terms of memory and thinking. There are 515 of you. So 65 and older would be HASD and ADRC, and 515 participants, and all seen annually. The abbreviation ACS stands for the Adult Children Study. These are individuals who are 45 years and up, and they are in the program because in most cases they had a parent who was affected with Alzheimer's disease. We see people who are in the Adult Children Study every 3 years, not every year. And then the DIAN study is part of an international study that we lead at Washington University. And this is a very rare form of Alzheimer's disease in which there's a gene mutation that runs through the family. If you inherit that gene mutation, you develop Alzheimer's disease 100%, and usually at an early age, somewhere around 45 years on average. So if you total all those up, we have over 800 participants enrolled in our 4 grants. The age range at Washington University is 22. Those are some of the DIAN participants. They come from families in which there's a gene mutation, up to 103. And 53% of you are women and 12% are African American. So that's something about you. Now, how many times do you come for your annual assessments? So we're very grateful for you coming. It is coming here at each time you are asked to come in for an assessment that is most important, because we need to know how memory and thinking and brain structure and brain function and blood values should work over time. Any of you who have had a relative or a loved one with Alzheimer's disease dementia knows that the way that we recognize it is that the individual is becoming impaired over time. It's this annual evaluation that allows us to compare the individual with what they were like a year ago. That's the most important evaluation. So you do a terrific job at coming in frequently. On average, you all are with us for at least 6 annual assessments. That's terrific. The longest person that we had participate every year, by the way, every year, 27 years. Where do you live? In this metropolitan St. Louis area. Well, there are the zip code breakdown. 17% in the city, about 48% in the county. But we have a fair representation from people outside of the county and the city, other Missouri areas and Illinois, and some people come to visit us every year, even though they live in different states. All right, lumbar puncture, spinal tap. We've talked about this at previous meetings. I just will reiterate, why do we ask for spinal tap? The brain is inside the skull, right? The skull's very hard bone. If we didn't have any protection inside the skull, whenever we turn our head, our brain might hit up against that hard bone. So the brain is bathed inside the skull with a fluid to cushion it. The brain sits in fluid. That fluid is manufactured in the brain. It surrounds, protects the brain, and also goes all the way down the extension of the brain in the spine called the spinal cord. So it's the same system, produced in the brain, protects the spinal cord. Any abnormality that happens in the brain will be reflected in the spinal fluid. You probably have heard of people who might have an infection of the lining of the brain called meningitis. How do we diagnose meningitis? We take spinal fluid, because it's the same fluid system, and we find the bacteria that is causing the meningitis and all the inflammation cells that are trying to fight that bacteria. We diagnose brain inflammation, brain infection by spinal tap. It's the same with Alzheimer's disease. It's not an infection, but we know that some of the essential proteins of brain cells are misguided in Alzheimer's disease. They're misfolded, and then they don't do their proper function, and brain cells die. We can examine those misfolded brain proteins from the brain caused by Alzheimer's disease by examining the spinal fluid. So we ask for the spinal fluid not because we are particularly cruel and inhuman investigators, but because it is essential for us to understand the workings of Alzheimer's disease. It's critical to our studies. So how many of you have had a lumbar puncture? 70%. That's remarkable. Okay, let's see your hands. That's remarkable. Thank you all. That's really terrific. Now, how do you perform? We get this question from time to time. We test you, and you want to know how your memory, you individually, are doing compared to other people. Are you slipping? So I have the answer for each of you here. I've spent a lot of time looking at each of your records, and I'm going to give you the answer. How are you doing? You're all great, so no worries. Okay, recruitment. We recruit about 100 new individuals into our program each year. As I told you, we have both people with Alzheimer's disease, dementia, and healthy people from 45 years and up. We do need volunteers who have mild Alzheimer's disease dementia. Mild Alzheimer's disease dementia. We want to enroll about 25 such individuals each year. Thus far in 2013, only 7. So we ask your help. If you happen to know someone who is 65 and older, generally in good health, but is experiencing memory difficulty that's starting to interfere with that person's ability to carry out their usual activities, we would like them to consider enrolling in the Alzheimer's Disease Research Center, the Memory and Aging Project. As you know, we need a study partner to come with them, and we would like them to be eligible for all of the studies that we do, including the lumbar puncture, the spinal tap. But we ask you to let us know if you're aware of any such person. You can call our Memory and Aging Project number. It's area code 314-286-2683, and you have that number in your handout. So please let us know. You ask questions. You are not a shy group. Why do you have to bring some with you? It's an imposition on some people, or you think it could be an imposition. It goes back to what I was saying about change. We need to know how a participant is doing compared to how they were doing a year ago or 5 years ago or 10 years ago. And certainly at the first time you come in, we have no idea how you were doing, but someone who knows you well can let us know whether or not there has been a change, a decline, and if so, in what areas. Very important for us to be able to get the opinion of someone who knows what you were like a few years ago and knows what you were doing a few years ago and how you're doing now. It's just very, very critical information for us. The spouse comes too to serve as my study partner, but you won't let her enroll in the study. We don't want the study partner to also be a participant, because if you're a participant, then you'll know the questions that we're going to be asking. It gets murky. So we've had a stipulation that you can't both be a study partner and a participant. My doctor doesn't think I have Alzheimer's disease. I don't still need to come, do I? So I'll tell you, whenever someone has enrolled in our study, even if it turns out they have dementia that's caused by another disorder, we still want to continue to assess people. We don't want to learn simply about Alzheimer's disease. There are other illnesses that cause dementia, and we want to learn about those too. So even if you don't think, or your physician doesn't think you have Alzheimer's, we still are interested in following you. I've been coming a long time. How long do you want me to keep doing this? Well, I would say 27 years is a good number. Once again, it's that ability to look over time that is so valuable. So as long as you're willing, we would love it. Each year I get asked the same question. Isn't there something new you can ask me? So there are two answers to this. One is, we do want to know how you're doing on the very same question, because that, if you don't do as well this year, that represents a change. If we ask you a different question than we asked you last year, we wouldn't know that that would be a change. So we have to ask you the same questions. So we see if you still perform well. Second, anybody who asks me this question, who remembers the questions they were asked last year, is not having any problems. So I usually come at a certain time, and this year you call me at another time. Well, we try as much as possible to get people in on their so-called anniversary date, but we can't always do that. And we are working hard to try to get that, and Joyce Skid is our scheduler and does a great job, but she has to deal with everyone's schedules, the nurses, the doctors, you and your study partner, and we try to get it at the same time, but it can't always work out. I mentioned we're having renovation and expansion at our building at 4488 Forest Park. Everything has been mostly completed except my office. I still have to unpack some things, but it's basically finished, and we have now about 50% more space than we had before, because we've moved to other floors, some of our offices on other floors of the same building. So the first floor, the Memory and Aging Project, that's where all the assessments are done. We've renovated the waiting room, we've added a new exam room, and a new laboratory to do blood collection. And here's our new waiting area. And I know some of you have been there. Here's our new blood collection room. Everything is brighter. It was kind of dark and dingy, and everything's brighter and freshly painted, and new things, a new examination room. testing, you know, all those wonderful tests that our psychometricians ask you, and bright new facility, so hopefully you won't feel so badly when you can't answer some of the questions that are, when you walk into the building, we call it the entry level, that's where our administration suite and our education core now. The lobby has all been very much brightened up. We have signs now, the Knight ADRC. That doorway is entrance into our administration suite, and there Dr. Buckles and myself are working hard in our new conference room. It overlooks Forest Park Avenue. And then up on the third floor of the same building, new space for offices. Here's a poster from one of our faculty, Dr. Randy Bateman, announcing that he was named the Knight Distinguished Professor of Neurology, and up in the upper inset, a photograph of Charles and Joanne Knight, who have been enormously generous benefactors for us, and and have endowed our center, and that's why we're proud to call it the Knight Alzheimer's Disease Center. This year our education core was very innovative. And spent a great deal of time to launch a new program, Dementia Understanding Opportunities, in conjunction with our medical students at Washington University, particularly as they enter their first year. You may not be aware that basically the first 2 years of medical school are going to lectures and classrooms and laboratories, and it's only in the third and fourth year that they're rotated into the hospital so they can learn about taking care of patients and come to clinics and see patient care. So the first 2 years are really limited access to patients. And we thought, Jennifer Phillips and Andre Denny thought that we would see if some first-year medical students would like, on their own time, to interact with a person with mild dementia. And we thought that this might be valuable to the medical students so they can learn about dementia and learn about how families cope and adjust to this. And we thought it would be valuable for our mildly demented individuals because they still have a great deal to offer and can explain how the illness has affected them. So we piloted it this year with medical students. I think there were a total of 7. It says 7, so I'll tell you 7. And I think it was a very popular program, and we'll probably double the number of medical students that will offer it next year. We call the individual with mild Alzheimer's disease dementia the mentor for the medical student. Of course, the family, the spouse often is heavily involved as well. And if anyone would like to participate in this, there's Jennifer's phone number, and you might consider this we will start it in August or September when the new medical school classes come in. There may be some duo participant mentors who are here today. Is anyone here who participated in the program and helped mentor a medical student? And can you, am I saying it correctly? It turned out to be a valuable program. Is that correct? Yeah. So if you're interested in it, give Jennifer a call, and we hope that in this way not only will medical students gain experience with patients, but they'll come to understand that dementia is not a stigmatizing illness, that these are real people with much to offer, and hopefully, ultimately attract them in their medical careers to solving the problems. So today you're going to hear about, from a group of 4 speakers about what some of our research initiatives are doing. You're going to hear about healthy aging. And, we've all had the idea that as we get older, it's inevitable that we're going to lose memory and thinking ability, and we'd like to at least challenge some of those assumptions. There is a very interesting connection about sleep and Alzheimer's disease. sleep and Alzheimer's disease. I'll just foreshadow the talk. And I think you'll find this is good news. The more you sleep, the less your risk of getting Alzheimer's. Isn't that good news? And I mentioned biological markers to be able to evaluate the presence of those abnormally folded proteins in the brain that we think are important to cause Alzheimer's disease. We have potentially a new biomarker being developed right here at Washington University, and I think you're going to like this one. I'll foreshadow this one because not only is this new biological marker, which represents a protein called tau that is important in Alzheimer's, not only might we be able to detect this in the spinal fluid as we do the other biomarkers, but there's some evidence we might detect it in the blood. Now, I know you all hate to give up getting your spinal taps, but just in case, we want to follow them. And finally, as I mentioned earlier, today we'll hear from one of the speakers about why it still is essential and so valuable to obtain the brain for autopsy in people who have participated in our program and have died. So you'll hear about the value of brain autopsy. In coming months, I just will comment another, we're not going to present this here because it hasn't yet gelled, but we may do a new partnership with something called the Connectome. This is an imaging study of 4 leading academic centers, WashU, University of California, Los Angeles, Mass General Hospital at Harvard, and University of Minnesota, to really understand how the brain is wired, how it's connected. It's very intensive imaging. And they started out with people in their 20s and 30s, but they want to look to through the lifespan, so in the 40s and 50s and 60s, 70s, maybe even 80s. And so they've come to us wondering whether we might partner on this, and some of our memory and aging participants might want to participate. So it's a map of all the connections in the brain performing MRIs. Presently, it's on twins who are 22 to 35, and this is some of the early work on that. You can see the various pathways and connections and how they're interconnected. It's an amazing study. And just to let you know, if we do partner with this group, we may come to you in the future and ask if you would be consider volunteering to participate for these MRI scans. We're going to try to get some funding to allow that to happen, and we may come to you for participation. All right, I mentioned earlier that we've been very disappointed, very discouraged by all the failed trials of experimental therapies. Here are some of them. Most of them, not all, most of them address a protein, one of those misfolded proteins that we think is critical to starting Alzheimer's disease, called amyloid beta, here abbreviated with a capital A and a Greek letter B. And there are 8 drugs that have been tested in people with Alzheimer's disease dementia, and you can see the outcome, all negative. None of them benefited. And some other studies targets other than amyloid beta also have failed. Now, why is that so? This is hypothetical. We don't know this, but our biomarker emphasis is giving a lot of support for this idea. So what I've put here is that the symptomatic phase of Alzheimer's disease, when Alzheimer's disease dementia is present, we think lasts about 7 or 10 years on average until death occurs. Now, what's going on in the brain during those 7 years when people already have the symptoms of Alzheimer's disease? Well, basically, nerve cells die, brain cells die. That's why the brain shrinks, so that's something that happens. But there's a lot more that goes on. There's abnormalities of tau, there's changes in the inflammatory nature of the brain, there's stress about the energy that the brain cells need many other things, vascular changes. All of the drugs that have failed have been addressing only one of these mechanisms, only one. Amyloid beta, which we think is involved in that nerve cell death. Treating with a single drug with all these other pathologies going on doesn't make sense, at least not to me. I think we need combination therapy. We have to address all of these processes. In addition, the very bottom encased in red is nerve cells have already died by the time symptomatic disease is present. And all of the failed drugs have been given only to people with Alzheimer's disease symptoms, with dementia. By the time dementia occurs, the brain is damaged. Brain cells are lost. So it makes sense to us to go before the symptoms appear. And this is what our biomarker studies have been teaching us. There's a period of perhaps 20 years before the dementia occurs in which some of these brain changes are building up in the brain, including perhaps that amyloid beta. And these are some of the biomarkers that you have contributed to that allow us to develop this hypothesis that there are changes in the cerebral spinal fluid in amyloid, and the imaging for amyloid, and the cerebral spinal fluid for tau, and the way the brain structures are. You have contributed to this. There is this preclinical stage, no symptoms, perfectly normal in memory and thinking, but ultimately, all of those changes that we're monitoring with the biomarkers reach a threshold where nerve cells die, and when they start to die, that's when the symptoms begin. So our approach, increasingly, is to try to identify this pre-symptomatic, preclinical stage before the brain is badly damaged and initiate therapies then. And we've started that. We've started that therapy. Well, this isn't it. I guess I put this in because I know a number of you are interested in what other strategies there might be coming up, and some of you have heard about insulin. We're going to be part of a national study of insulin because the brain has some insulin targets, and we think that there's an abnormality about how, in Alzheimer's disease, about how insulin is recognized and whether it can do its work appropriately, and the brain may become resistant to insulin. But we can't give insulin the traditional way that we give people with diabetes through the vein, because people with Alzheimer's disease who don't have diabetes, that insulin would drop their blood sugar. But there's a way now to deliver it through the nose, intranasal insulin. Avoid giving it through the blood so it gets directly into the brain. And so that trial is going to begin probably in the fall. I just alert you to this case once we launch it, if anyone would be interested in participating. But here's what I really wanted to end on: prevention. There are these prevention studies that are launched. The first one to launch is the very bottom one. It's our study. It's led by Randy Bateman, who I mentioned earlier. The Diane Trials Unit is testing in people who carry a mutation that will cause Alzheimer's disease, but they are not yet symptomatic. They haven't lived to the age in which symptoms appear. We're trying 3 different drugs to prevent or at least delay the onset of symptoms. The Alzheimer Prevention Initiative by our colleagues in Arizona, Eric Ryman and Pierre Theriault, are going to do a very similar study. In South America, there's a very large family with a mutated form of Alzheimer's disease, and they're going to try a drug there. And then in late life, and we don't know if this is going to start later this year or next year, in people who don't have the inherited form, which is very rare, but healthy older people who might be biomarker positive. And they think the way they're going to identify this is some of that amyloid imaging, those PET scans. They're going to give them drugs to try to prevent or at least delay the onset of Alzheimer's disease. So we've started the era of prevention therapies in Alzheimer's disease. And I'll just end with this slide because we have the first prevention study at Washington University started this year. Matter of fact, the first person enrolled on New Year's Eve 2012, and they were given the drug in March at our site. And matter of fact, our site is already enrolled 4 people and given drugs to 4 people. So this is a very momentous, in my opinion, very momentous opportunity to try to prevent Alzheimer's disease. The first ever trial has begun to prevent Alzheimer's disease. We all are very hopeful that this shows benefit. If it shows benefit in these individuals from these rare families with mutation, of course, then we will extrapolate to the far more common form of Alzheimer's disease that begins in older adulthood. So it's an exciting time. We do have challenges. We remain extremely grateful to all of you for your participation. You will now hear from our 4 speakers about those topics I mentioned, and then at the end, I'll ask them all to come up here and we'll have questions and answers. And at your desk should be, are there index cards? Yeah, and pens. And if you have questions, you're to write them and bring them up here so that we can address them. So thank you all for being here. It's a pleasure to see so many of you interested in Alzheimer's disease. Thanks. All right, so now we're going to hear from Rachel Chassie, a psychometrician who's working with Jason Hassenstab, our neuropsychologist, to talk about cognitive or memory and thinking abilities in cognitively normal older adults. So please welcome Rachel Chassie. Let's see,
Thanks for marking me up. Hi everyone, I'm Rachel Chassie. I have been working on this project for quite a while now with Dr. Jason Hassenstab, assessing supernormal cognition in older adults, affectionately referred to as the supernorm study. So I'm sure everyone's favorite part of partaking in the Knight ADRC is the wonderful paper and pencil testing of thinking and memory. We have all of this rich data from every single one of you in multitudes of cognitive dimensions, with different forms of memory and such. But what do these scores really mean? What do we do with them? Essentially, a score is kind of meaningless unless we can put it into some sort of context. So now, if someone receives a score of a 16 or a 12 on a certain test, what does that really mean? How do we give these scores value? So now let's take a look here on the left. So the maximum score on the first 3 tests is a 3, but this person scored a 2 on that second test. I mean, that's not too bad. I mean, it's only 1 point away from the maximum anyway. But what does that mean? But if you look to the right of the screen, we can see that that score of a 2 actually falls within the 36th percentile of that test. So now that means that of 100 people walking on the street, this person scored better than 36 people on that same test, but worse than 64. So it perhaps isn't too good of a score whenever we put that into perspective. We can only give scores true meaning when we compare them to a reference group. This reference group needs to be a type of gold standard, one in which all scores are to be compared. This gold standard reference group is referred to as normative data, or norms, named such due to them being, well, normal. Ideally, normative data is representative of a population. So they represent a range of people, taking into consideration age, race, gender, education level, and other demographics. So now normative data needs to be of the highest quality. It is the gold standard, after all. As normative data is what all scores are to be compared against, it needs to be of the cleanest, healthiest sample possible. However, some individuals may find themselves in what can be defined as a preclinical stage of Alzheimer's disease. So this is where individuals show no symptoms, but biomarkers within the brain and spinal fluid suggest that they are in the earliest stage of AD. And Dr. Morris spoke of this a little bit earlier. So now this line here, right here. So this line here represents the point of time in which people are diagnosed with Alzheimer's disease. So 5 to 10 years before this diagnosis, there are some changes in memory and some physical changes in the brain. And in some other markers of the disease, these physical changes can show up 20 years before clinical diagnosis. So now for this study, I heard someone say wow over there. Yes, wow indeed. So now for this study, we wanted to create what we would call a super normative group. So now this is rather difficult to do because in older populations, about 1/3 of people have a form of preclinical Alzheimer's disease, but show no symptoms. So these individuals are often included in these normative samples, which actually makes it harder to detect very subtle declines in memory and thinking. So in other words, the standard that scores are compared to is not quite as high as it should be, and that makes detecting decline more difficult. So we wanted to find what happens to normative data when we put together a group of people who have had brain scans and lumbar punctures, but show no evidence of Alzheimer's disease. So this group would represent a fairly disease-free sample, which would be used as a standard and help us and other groups around the world detect declines in memory and thinking much better. So now at the Knight ADRC, we are so fortunate to have the most amazing participants in the world. Everything that you all agreed to do, including all of the memory and thinking tasks, the lumbar punctures, the brain scanning, the questionnaires, and the clinical interviews, has allowed us to put together one of the most sensitive databases that has ever been created. Thank you so much for that, by the way. So now, this is how we moved forward with the supernorm study. We compared a supernormal sample with a preclinical sample. So now everyone in this study came into the Knight ADRC without any symptoms. However, the supernormal group has no evidence of AD whatsoever, whether from brain scanning we do or from the lumbar punctures we create. But on the other hand, the preclinical group, while still having no outright symptoms, came up positive on these tests. And as you can see, they're otherwise similar, so roughly the same in age, same number of men and women, etc. So here's what we saw when we compared the performance of the supernormal group, that lovely turquoise color, with the preclinical group in the salmon. So keep in mind that both groups are asymptomatic, so nothing appears to be wrong with either group in everyday life. But we do see some differences in their performances on memory tests. And so as we can see here, the supernormal group, the blue, does better on a handful of tests as compared to the preclinical group. Okay, so what do we do with this information? All right, so now this here is a rather busy looking slide, but I'll try my best to take you through it. So we looked at the different groups of participants who've been coming in for several years, and all of these people in this group started the study as normal with no symptoms, but did progress to a diagnosis of Alzheimer's disease, represented by, there we go, this point right here. This is the point at which they were diagnosed with Alzheimer's disease. So now, this top line here, in this pink, represents a sample of individuals where their scores would fall if we use a normative data set that includes people with preclinical AD. And the bottom line here in the blue represents where their scores would fall when compared to the supernormal data set, which has no evidence at all of Alzheimer's disease. So as you can see by the time point, you can see that, by the time people are showing symptoms and are diagnosed with AD, their scores have fallen quite a bit from whence they first came in. Okay, but if we blow up this figure right here, you can see that by comparing their scores here to the supernormal database in the blue, that we can see by comparing their scores in the supernormal database, we can see they have the same level of decline right here up to 3.5 years prior. Okay, so now our goal was to create a superbly healthy gold standard in which to compare cognitive data, one that is the most clean and disease-free. So this goal is very important as it allows for a truly effective reference group that puts actual meaning to cognitive scores. Because of all of you, we were able to do so and create our beloved Supernorms database. Then whenever we use the Supernorms database, we were able to detect cognitive decline on some memory tasks up to 3.5 years prior to clinical diagnosis on some tests, which I think is pretty outstanding. But what makes this study truly unique? Well, that's easy. All of you, all of our wonderful, faithful, smart participants. The Knight ADRC is truly one of the most unique centers in the entire world. We have a rich history of biomarkers that we gain from the brain scans and the lumbar punctures that all of you agree to do. Now, what makes that incredible is all of you. You all have come in year after year to help us with all these amazing tasks that a lot of centers aren't able to do because they don't have all of you. So again, thank you so much for helping us all, and please accept my very sincere gratitude for all of your participation in the Knight ADRC.
So I think you can see from Rachel's presentation, get that idea of multiple assessments in individuals over time and the emphasis on early detection so we can try to get interventions at the earliest time possible before the brain is damaged. So I mentioned sleep, and we're delighted to have Brendan Lucy, who's an assistant professor of neurology, come and tell about some of the different sleep studies that have been developing in the past few years at the Knight ADRC. So welcome, Dr. Lucy.
Thank you, Dr. Morris. I'm very excited to be here this morning to talk to you about a project that I'm starting in collaboration with Randy Bateman, looking at sleep and the amyloid beta protein. So what constitutes a good night's sleep? There's a couple of factors that are very important. And if you're like me, you want a good night's sleep, you want to maximize all of these things in order to feel as refreshed as possible in the morning. Sleep follows a day-night pattern or diurnal pattern. That's what's most enhance your likelihood of having restorative sleep at night when you are awake during the day and sleep at night. You have to cycle through several different sleep stages, and I've shown a graphic on the slide of what we call a hypnogram of an individual sleeping overnight and cycling through the different stages, stage 1, 2, 3, and rapid eye movement or REM sleep. And part of having good restorative sleep is that you cycle through these stages several times throughout the night. And you have to sleep long enough in order to do that cycling. Average sleep time is probably on a population basis, 7 or 8 hours, but some people need a little less, some people need a little bit more. It just depends on the individual. So why is a good night's sleep important in Alzheimer's disease? There's been a number of recent studies that have associated some sleep problems with an increased risk of Alzheimer's disease. One of those problems is sleep fragmentation. This might be waking up frequently throughout the night, interrupting that cycling of the sleep stages that we just looked at in the previous slide. Decreased sleep efficiency has also been associated with increased risk of Alzheimer's disease. Sleep efficiency would be where you go to bed at 10 p.m. at night, you wake up at 6 a.m., that's an 8-hour period, but you only slept for 4 hours of that 8 hours. So you'd have a 50% sleep efficiency, which would be poor. Sleep time has also been associated with an increased risk of Alzheimer's disease. Sleeping too short, 5 hours or so, or sleeping too long, up to 11 hours, have both been associated with an increased risk of Alzheimer's disease. And then more recently, a couple months ago, a paper came out from Washington University, where one of my colleagues, Yoel Ju, in the sleep division, and David Holtzman performed a study involving memory and aging project participants, where they looked at the sleep-wake cycle with something called actigraphy, and we're able to associate changes in the sleep-wake cycle, specifically sleep efficiency being decreased, with amyloid deposition in the brain as seen on imaging. And this is an important finding because those individuals were all cognitively normal, but they were able to sort them out by the change in the sleep efficiency in terms of their amyloid deposition. So amyloid deposition in the brain is a key step in Alzheimer's disease development. And we know that higher levels of amyloid beta in that fluid around the brain that Dr. Morris talked about can be associated with amyloid beta deposition. And recent work also done at Washington University has found that that level of amyloid beta in the fluid around the brain fluctuates with the sleep-wake cycle. So when you're awake, that level is higher, and when you're asleep, that level is lower. This is a graph showing that diurnal pattern where the amyloid beta changes with sleep and wakefulness. This is an individual over approximately a 36-hour time period. And the red line would be the amyloid beta concentration measured at each hour time point in the fluid around the brain. And the green line is a best fit for that data. And I put an arrow for when sleep would start, say that's 9:30 or 10 o'clock at night. And you can see by the other arrow that following that sleep onset, the level of amyloid beta in the fluid around the brain is decreasing. So my pilot study is proposing to examine if we can do an intervention, do a manipulation of sleep in an individual, and then change the amyloid beta concentration in the fluid around the brain. It's not known if this can be done in humans. Our prediction would be that in individuals who are sleep deprived or kept awake, that there would be an increase in the amyloid beta concentration in the fluid around the brain, and that individuals who are induced to have more sleep would have a decrease in the amyloid beta concentration in the fluid around the brain. So for this pilot study, we're proposing to recruit 12 participants from the adult children study, ages 45 to 60 years old. There's a variety of medical problems that can result in exclusion from the study due to safety concerns. And as you'll see as we go forward, we're going to be asking a lot of participants in this study, so there will be some compensation. For the study, individuals will be admitted to the clinical research unit, and 6 participants will undergo sleep deprivation, and 6 participants will have sleep induced with a medication called sodium oxybate, which is a potent inducer of sleep and is FDA approved for the treatment of for narcolepsy. And then we would ask those participants 4 to 6 months later to cross over to the intervention that they did not undergo the first time. So if they had sleep deprivation initially, 4 to 6 months later, we would ask them to do sleep induction. This graph shows an overview of the study. Once enrolled and before admission to the clinical research unit, we would like to monitor your sleep in the home. The home setting is where sleep is most, it's going to be the most perfect place for you to sleep. It's where you sleep most of the time, where you're most comfortable, and it's going to give us the best sense of what your true baseline sleep is. And then the first day of admission to the clinical research unit, we would do another baseline day to see how you're sleeping in the new environment of the clinical research unit. The second day would start the sleep modification, where at the beginning of the day there would be a lumbar catheter placed for collecting that fluid around the brain, IVs, and then sleep would be either deprived or induced depending on what arm someone was in. And then after 36 hours, all those tubes and IVs would be withdrawn and be allowed to rest before being sent home. So this figure here just shows what you might expect in the clinical research unit. I'm partnering with Randy Bateman in this project, and we're going to be using his protocol for hourly CSF collection that fluid around the brain that he has done in over 200 participants. And I'm sure there are many people in this room who have undergone this protocol. As you can see from the figure, there'll be sleep monitoring with an EEG device, and then fluid collection, collection of the fluid around the brain every 1 to 2 hours. And there'll be some video monitoring for safety. The sleep induction group will take the medication to induce sleep at night and to enhance their sleep. And they would be allowed to nap throughout the 36-hour period as they might wish. The sleep deprivation group will use coffee and movies, books, and any other measures that are reasonable, such as pressing the nursing button every few minutes so the nurses know that you're awake, to stay up. And so the prediction is that those individuals who are sleep deprived will have a rise or an increase in the amyloid beta protein, the fluid around the brain, and those who are sleep induced would have a decrease. And I think this study could provide a very interesting and essential finding into understanding the mechanism for why those sleep problems that we went over earlier are associated with an increased risk of Alzheimer's disease. It also provides a potential avenue for treatment. A lot more research would need to be done to know, is it the specific medication, the sodium oxybate, that's driving down the amyloid beta protein? Or can you use a different sleep medicine? Or is it simply lifestyle modification and behavior to enhance your sleep, keeping normal wake and normal bed and rise times, for instance, that are really the essential component. So I think it's a very exciting study that could open up a whole new avenue of research in this area. So thank you very much for your attention and for your participation in the Memory and Aging Project.
So we have one of the strongest neuropathology cores in the Alzheimer's Disease Center Network, and our neuropathology core leader is Nigel Cairns. And Nigel, you were seated over there. Are you still seated? Will you stand up? Oh, he moved. Nigel moved over here. And from Dr. Cairns' laboratory, Aaron Householder, who joined just about a year ago, is here to discuss the value of brain autopsies. So welcome, Ms. Householder.
Good morning, everyone. It was very exciting for me to learn that I would be speaking to you today. I don't ordinarily get to interact with the participants at the Memory and Aging Center. We're located in a different lab, but it is, I'm very happy to be here today and get to speak with some of you. So basically, I'm going to talk to you about the brain donation program that we offer through the Alzheimer's Disease Research Center. I want to discuss some of the reasons why brain autopsy is very important. One thing that I truly didn't understand until I started working in this field is that, and Dr. Morris mentioned it earlier, is that Alzheimer's disease is only definitively diagnosed at autopsy. And through our lab, this diagnosis is provided to family members. Clinical data about memory and thinking from the Memory and Aging Project study visits can be used to compare with what we find in an individual's brain. So basically, the correlation of clinical and pathological data or information is invaluable to our clinicians and investigators in understanding the normal aging process, Alzheimer's disease, and other types of dementia. And there is no other way to obtain this critical research information. This is just a copy of the brain donation brochure, and that can be found up here at the EdCore table. Some of the topics that are outlined in the brain donation brochure are that autopsy obviously involves removing the brain, which is then carefully examined by our neuropathologist, Dr. Cairns, who Dr. Morris just pointed out. The entire procedure is conducted with full respect for the dignity of our donors, and the autopsy is undertaken at no cost to you or your family. One thing that people are sometimes concerned about, their face is not disfigured during the autopsy, and you can still have an open casket funeral, and funeral arrangements are not delayed in any way. You must inform your family of your decision to donate your brain, since they will make the final decision upon your death. At that point, we won't be able to ask you about the process, so it's important that you let them know, and that will really aid them in making this decision. As Dr. Morris likes me to point out, we promise this truly does not hurt. As I said, autopsy arrangements are made ideally before death with the Memory and Aging Project staff, which you saw stand up earlier, and you all have had the pleasure of working with them, as I have the pleasure of working with them. They truly make this process very easy on your loved ones, and they're available 24/7 to receive all the calls in the event of death, and to initiate the autopsy procedures with your loved ones. The nurses also arrange the transport of your body to from the place of death to Barnes Jewish Hospital. We have some wonderful staff there that actually perform the procedure with the residents at the neuropathology division. So after the autopsy, the family is responsible for transport to the funeral home or crematorium, but the Memory and Aging Project staff make that very easy for them to do. So basically, I want to show you a picture of a Alzheimer's disease brain that you see at your left, and then a normal aged brain at the right. Dr. Morris mentioned the neuronal loss that occurs, and that's due to some microscopic lesions of AD. And you can see here, let's see if we can get this dot going, the neuritic plaque here at your left, and neurofibrillary tangle here at your right. Here's Dr. Cairns and our lab manager, Deborah Carter, myself. Basically, Dr. Cairns reviews these slides under the microscope very carefully. There are very many slides that he looks at to make this diagnosis that I mentioned is shared with your family members. And so basically, I know there are probably some questions, and we'll have a question and answer session after this, but our lab is composed of Dr. Cairns, Deborah Carter, who is our lab manager, myself, I'm the neuropath coordinator, Ben Vincent is our new lab technician, and Ming Cheng Shi is our staff scientist. And we're all encompassed in the Betty Marks lab for neurodegenerative research. This is just a picture of Miss Carter, myself, and Ben at a Cardinals game earlier this season in support of the Alzheimer's Association. So we were close lab, and we really appreciate your donation to further this very important research.
All right, thanks very much, Aaron. So now we're going to welcome back up to the podium Rachel Chassie, Brendan Lucy, Mark Diamond, and Aaron Householder. And our intrepid Memory and Aging Project staff is collecting your questions on the index cards, and I'll sort of moderate here. And we'll try to get through as many as we can, but we won't get through all. So don't be disappointed. Legibility is valued. And I'm going to begin by asking Dr. Diamond to respond to a question about a recent query about metals in the brain, and do they contribute to Alzheimer's disease pathology?
I don't know for sure. I would think probably for most of us, the kinds of exposures that we get for, say, cooking from an aluminum pot or something are negligible and have no effect. I can't say that for people who were have some sort of really abnormal exposure that there might be something, but I'm not super convinced by any of this.
Okay, I'll take a stab at that one. So, as Dr. Diamond points out, there's been a long-standing concern by some people that aluminum can predispose having Alzheimer's disease, and Mark has correctly said that there is no evidence that aluminum causes Alzheimer's disease. But you've heard something about the fact that we have these abnormal proteins, and they can aggregate in unusual forms or shapes or structures, and then the brain isn't well positioned to handle those abnormal structures, and they can get deposited as tangles and plaques. And there's some evidence that some metals, iron and copper in particular, may play a role in that formation of some of those deposited aggregates. There are some companies that are trying to look at reducing metals. To date, there is no evidence of any benefit from these trials that have been done. But in Alzheimer's disease, we are open to lots of ideas, and if there's sound support for some of these ideas and agents that might manipulate them, we're willing to consider them. Is that fair? Okay. Okay. How does one arrange an autopsy for brain donation? Aaron, you're going to take that one.
So basically, the Memory and Aging Project nurses and clinicians can't hear me? Sorry, is that better? Okay, sorry. The Memory and Aging Project nurses and clinicians at any of your study visits are able to talk to you about the brain donation and can provide you with any information that you might need on logistics regarding the autopsy. You can make the phone call if it's not at one of your regular study visits. You don't coordinate directly with the neuropathology core. It's all through your clinical visit that they would arrange the consents and potentially discuss any of the details with your relatives or study partner that might be involved in making those arrangements at the time of death.
Right, so thank you for that. Memory and Aging Project visits should provide everyone with the opportunity to learn about brain autopsy donation. And if it doesn't, speak up, because we're supposed to let you know each time. Brendan, what about sleep apnea? Any role of sleep apnea in Alzheimer's disease?
There have been a number of studies recently looking at sleep disordered breathing or sleep apnea, increasing the risk of developing cognitive impairment or Alzheimer's disease that have been done. And I know there's a number of groups that are looking into that.
Okay, so it's being investigated, but no firm link at present?
Correct.
Is that correct? Rachel, here we've been talking about intranasal insulin and tau antibodies. What's going on in the way of research at our Alzheimer's Disease Research Center or others about non-drug therapy? Is exercise, is that important? What about diet? What can you say about that?
Exercise is very important. At least a healthy lifestyle, not only dealing with Alzheimer's, but towards in different facets of your life as well. It helps with things as blood flow, which we also know helps normal cognition, normal functioning as well. What was the other part of the question? I'm sorry.
What about diet?
Diet is also helpful for the other reasons as well, too.
What kind of diet?
Healthy, very good diets.
Eggs, bacon, sausage?
Of course, yes, nice, healthy, saturated diets. No, so really great, lots of green leafy vegetables and fruits and these types of wonderful things do help just normal functioning and cognition in general.
So just to expand on Rachel's, several investigators, including Rachel's colleague Jason Hassenstab and also Denise Head at our Alzheimer's Disease Research Center, are doing a lot of work on exercise and finding that, remember we talked about the biomarkers in the pre-symptomatic phase, people who exercise are less likely to develop those biomarkers. So that's some support for that idea. All right, now, Rachel, I'm going to keep with you for just a moment. So you talked about paper and pencil tests. Are we going to move to computerized testing?
Are we going to move to computerized testing? What a wonderful question. So a lot of the tests currently work best with paper and pencil, such as the ones that require drawing and these types of things, but perhaps in the future we are investigating our options to get to go digital in a lot of different aspects of our research, and with especially as we all age, we become a lot more comfortable with electronic devices, these types of things too. So perhaps in the future we will, but for a good amount of time we're still sticking with our good old paper and pencil. They seem to be rather effective at this point.
Okay, Brendan, so some people take sleeping pills and get more sleep with sleeping pills. Is that beneficial to their amyloid? What's the role of Medicaid sleep meds?
That's an interesting question.
That means he doesn't know.
And that's one of the purposes of the study, to first show that we can, increase sleep, and we're going to be using a medication in this case to decrease amyloid beta levels. But if it were to work, a sort of logical next step would be to look at other medications, or to look at just doing things to enhance someone's normal sleep, behavioral changes, like I talked about, lifestyle changes. And is that all that's needed to drive down amyloid beta levels?
Okay. Dr. Diamond, can you explain what the fluids are that we're really testing? Is there a difference between spinal fluid, blood, plasma? Can you explain all of that?
Sure. In our test in the lab that I described, we took pure spinal fluid. There's two things that we looked at. One was spinal fluid, which is basically just pretty much as it comes out of the needle that's put in your back. We dilute that about 2,000-fold into the media that bathes the cells that we grow to test for the presence of these abnormal things. So it just goes in straight. And for plasma, that's blood products, that's blood that's drawn, and then they spin out all of the cellular products. So it's basically just a clarified, kind of yellowish solution, and that's diluted also, but about 40-fold into our assays. So pretty much we're just looking right at the stuff as it comes out of you.
Right at the stuff as it comes out.
There's no processing. We're not doing anything special to it. Okay. All right, Aaron. So if someone does have brain autopsy, does the family get a report of the findings?
Yes, the family does get a report of the findings. Basically, once Dr. Cairns is finished making his diagnosis and our neuropath division signs out the report, we can release it back to the Alzheimer's Center, and one of the Memory and Aging Project staff members will contact you with the results, so the report that we create is fairly complex, and they can help you to understand some of the points that Dr. Cairns has found in the examination.
What is the time frame for that report?
The time frame is approximately 6 to 12 months. There are a lot of things that are included in the diagnostic workup, so I can detail some of those, but that's our standard amount of time. So,
how many brains does the Alzheimer's Disease Research Center Neuropathology Core study per year?
Per year is approximately, through just the ADRC participants, I would say approximately 70 to 80 brains per year, but that can vary.
We have one of the largest repositories of brain tissue, and under Dr. Cairns' leadership, not only is the brain tissue processed in order to allow the diagnosis to be made or not, and the report generated to the family, but much of the brain tissue is kept under very special conditions, frozen conditions, to allow for biochemical and genetic and other studies. So it's a resource for research beyond just knowing what the diagnosis was or was not. It's a very valuable resource.
Can I add one thing about that?
Sure.
In developing the tests that we have been able to apply to peripheral samples like spinal fluid and blood, we relied on starting with brain material. And that continues to be a really important resource for us. So it's not just when you're alive that you can help.
So a number of you, and I thank you, have responded to my report about the constraints and the dire environment for funding at the National Institute on Aging, and asked how are we responding to that. And I can tell you that we have been sustained in our research mission by a combination of partnerships and by philanthropy. And I'll illustrate one partnership. Dr. Diamond mentioned that imaging can be very expensive, particularly this form of imaging that we've been doing called amyloid imaging. A particular form of amyloid imaging just in the past year has been approved by the Food and Drug Administration for people in clinical purposes, not just research purposes, to undergo an amyloid scan if they're having cognitive problems to see if they have amyloid deposits that suggest Alzheimer's disease. The cost of that scan is out of pocket $3,200. And no insurance company nor Medicare is reimbursing that. So that's just one example of how costly this is. So with so I'm illustrating our partnership, with the cutbacks in federal funding, we have gone to one of the companies that is developing these amyloid tracers, the scans that the scans detect the tracers if they have amyloid in the brain. And one company has offered, because of the value of the data that we've been collecting with you over these years, to give us the drug, and in some cases to even help pay for the scanning time so we continue our research. So that's one example of a partnership that we've just been developing. We were on the telephone yesterday to continue to see how we can leverage that. Another is philanthropy, and we have been very blessed at our Alzheimer's Center by the generous support of many people. I mentioned the Knights, Charles and Joanne Knight, but many other people have contributed to our efforts, and I am going to be blunt. I think that no longer, unless something dramatic overcomes sequestration and Democrats and Republicans start talking to one another, it's not going to change. And I think we'll be increasingly dependent upon philanthropy. And I know many of you have contributed in not only your time and your blood and your spinal fluid and so forth, but some of you have contributed, and we're very grateful. It's very appreciative, and frankly, I don't think we could do what we do without your philanthropy. So I am very pleased about that. And if any of you do wish to contribute, and you have unmarked bills, I will be over here afterwards. Seriously, it's a major support for our efforts. Okay, so let's see. Who will I give this one to? Maybe I should take this one too. I don't want to monopolize things, but here's a question about what is the likelihood of developing Alzheimer's disease dementia if you have a first-degree relative, a parent, who developed it in their 60s. So the younger the age at which your parent became symptomatic, the greater your genetic risk. If your parent developed symptoms after age 80, you probably have minimal genetic risk. The most risk you would have is if you live to age 80 is age, right? I mean, that's serious. That's the number one risk factor. But if in your family the symptoms appear in the 60s or the 50s or the 40s, your risk goes up. So yes, the younger the age at which your parent developed, the greater risk you have. Let's see now. By the way, I applaud all of you who have contributed such great questions. So I'll take one more, then I'm going to pass it on to the others. Some of you asked, can we accept brains for our autopsy program and in people who have not been participants? And the answer is no. We only take autopsies from people who we've been able to see in the Memory and Aging Project. Okay, here's a question about folic acid. Mark, what do you know about folic acid and Alzheimer's disease? Mark, wing it, wing it.
I don't know very much about it. Do you know much about it?
So there's been a long idea that people with nutritional deficiencies, and the most common one that's considered is vitamin B12, may be at risk of developing a neurologic problem that can present as dementia. It does not cause Alzheimer's. And in this day and age, vitamin B12 deficiency causing a dementing disorder is exceptionally rare. But the way vitamin B12 caused neurologic damage worked in conjunction with folic acid. So there is an interest in what the role of folic acid may be. I would say, and I think Brendan and Mark would agree with me, we have not seen cases of folic acid hyperactivity or underactivity causing dementia. It may be part of the mechanism of brain damage, but it's not a viable cause of Alzheimer's disease. Okay, so let's see. I'm not going to have Dr. Diamond again.
That's what he was doing.
Okay, Rachel, do you want to handle this one? Is education a factor in risk for Alzheimer's disease?
Education is indeed a factor. So the more education that one has and the quality of education, the less likely one is to dement rather soon, or even it also affects the trajectory. So the lower education that you have, unfortunately, the higher your chances of dementing sooner and more quickly. So the higher education seems to be a little bit better in terms of developing Alzheimer's.
Okay, so we don't, now it gets tricky. We don't know if the people, what Rachel said is absolutely true. People who are less likely to get Alzheimer's tend to be better educated than people who do get Alzheimer's. And you can make up an idea about that. Well, the more education you have, the more the brain is stimulated, the more connections it makes, it's stronger, it's more resistant. Maybe the people who were better educated grew up in a socioeconomic environment that allowed them to go get better education, and it wasn't the education, it was the fact they had better living environment, better diet, or more access to other things. Or maybe they were born with a bigger brain. And that's what led them to go get more education, but it wasn't the education that protects them, it was the fact they had a bigger brain to begin with. Does that make sense? So we're trying to figure out what's causal in all of this. Okay, so let's see here. Education, I did that. What's this one? Oh, Rachel. So you resonated with supernorms, and I think our attendees here today want to know how many of them are in that supernorm group.
What do we all like to know?
Everyone, right?
We are all, yes, every single one of us are involved in this study, indeed.
So this raises another question, and that is, we do provide autopsy results. Do we provide to you your individual research results, including whether you're in that supernorm group or not? And we don't do that. Now, why don't we do that?
Oh, I'm sorry.
Oh, you're going to answer?
Were you asking a question? I wasn't too sure.
I was asking a question of myself, but if you want to answer, go right ahead.
I'll let you take this one, Dr. Morris.
Okay, all right. So one thing is, to date, we don't know exactly what some of the research results portend. We don't know what that means. Rachel showed you some figures on cognitive test score. On one test, a score of 2 says you're in the 36 category out of 100 people, and that means you did better than 36 but worse than 64. Is that what she said? What does that mean? Does that mean you're demented? Does it mean you're going to get demented? We don't know. But when you learn your results, you want to know what it means, and we don't have that information yet. On the other hand, we appreciate that many of you would like to know, and so we are providing, some of you may have taken it, a study of what it is you would like to know, and whether once knowing it, if we were to give it to you, how that might affect you. So for example, just this, I don't mean to be alarmist here, but say you wanted to know whether your brain was full of amyloid after that amyloid imaging scan. Okay? I mentioned there's already going to be a trial, a study of a drug in people who do have amyloid in the brain. They're still healthy, cognitively normal, to see if it can slow down developing Alzheimer's disease in the future. Well, say you know that your brain is full of amyloid. You don't have symptoms yet. You hope that they're not going to get it. Say you go apply for long-term health care insurance. And your insurer says, are you in a research study? Well, yeah, I am. Is it an Alzheimer's? Well, yeah, it is. You have a test to see if you have Alzheimer's? Well, yeah, I did. What does that mean for you? So we're very sensitive to your concerns, but we are also trying to work through the gamut of concerns. So we will report back to you what the results of this, what your results, what you want to know about it after learning everything. All right. Let's see here. Can tau research be used for starting asymptomatic treatment earlier? Dr. Diamond, how do you see the tau research and the tau treatments going?
I think they're going very well. So we're this is what we're just hoping to publicize the work that I described to you, and basically expand this study. We're now starting to work with that Diane set, and we'd like to put these the detection of these abnormal proteins in the context of the other biomarkers in a kind of longitudinal study, so that we could begin to ask, well, when do these things really start to change in relation to the predicted onset of disease, and that will affect how they're used. I suspect at some level you want a test that switches from normal to abnormal before you get sick, but not too far before you get sick. In other words, it doesn't do us much good to say 30 years ahead of time that you're going to get Alzheimer's disease 30 years hence. No one can do a drug study to try to prevent that. You can't do a test in that way. But we have to sort of be able to parse people closer to the onset of disease. And so I think in that regard, the tau stuff might be very useful. And certainly there's a lot of interest from the pharmaceutical companies in terms of targeting tau the same way that amyloid beta has been targeted. Will that work any better? I don't know. I think it probably will, because we think that the tau protein accumulation is what correlates best with cognitive impairment, but that's speculation right now.
And just to follow up, I mentioned the amyloid imaging, and we're working with the companies that produce this to allay the costs that we have if they can provide some of the costs. Those companies are also developing tau imaging agents. So in the future, we may be doing both amyloid and tau imaging. And the second aspect on the therapeutic side is Dr. Diamond and an associate director of our Alzheimer's Disease Research Center, Dr. David Holtzman, are developing that very antibody that he illustrated that might block this process. It's not ready for trials in humans yet, but it's being developed. Is that correct, Dr. Diamond?
That is correct.
Okay, Aaron, what about brain donation if you die out of town?
Well, we do have associates across the country that have worked with us on doing the brain removal outside of town. We work with, obviously it's good to know somewhat ahead of time if the person would move out of the area, but we do receive a brain via a shipment, so it wouldn't necessarily be that your body has to be transported from out of town because that's often not legal. So we can work with pathologists or technicians to do that out of the area.
And we do that frequently. So yeah. So if you are signed up for brain autopsy and move away from St. Louis, we'll find a way to get the brain autopsy done.
It's just important that we know as soon as possible.
Right.
That's the case.
Does the brain need to be put on ice?
Yes.
So we used to think that the brain, after the person died, we had to pack the head in ice to prevent the brain from deteriorating before the autopsy. Some of you may have thought about that. Now that it would only be done in the most unusual situation. The brain autopsy program now does it quickly enough that the brain does not need to be put on ice. I've been told that if you're interested in more information on Dr. Lucy's sleep study, that the contact person is Becky Fearberg. Becky, are you here? And she's raising her hand and she's waving it. She's waving it, actually. There she is. And you can see her, or you can call the Memory and Aging Project. Listen, you all just amaze me at your wealth of knowledge and the great questions you have. I apologize for not getting through all of them, but can we all together thank our 4 panelists for their great presentations? So it is 11. I think Brendan and Mark and Aaron and Rachel will stick around. If anyone has questions, come on up. And always, it's a great pleasure to see all of you and have a wonderful rest of the weekend. Thanks so very much.